Good morning. We're just going to give a few more minutes for others to join us, and then we'll start in about 2 minutes. Good morning and welcome to our webinar this morning. I want to thank you for taking the time out of your schedule to be present with us today. My name is Debbie Nappy and I'm going to be your moderator for this program today. I am the lead partner for our firm's healthcare division at Saks. So you can move the slide. Today, our conversation today is going to be around New Jersey family care, which is also New Jersey Medicaid, and the changes that are effective beginning 1/1/25 for phase 1, which I will get to in a moment. Basically, New Jersey Medicaid is also comprised of New Jersey Medicaid and CHIP health insurance for children. Going forward, behavioral health is now going to be moved from a fee-for-service billing now to the New Jersey Medicaid managed care organizations, which further along in our program, we're going to discuss that there are 5 MSOs in the state of New Jersey that you will need to contract with. So currently, the behavioral health is billed separately from the overall health of a patient, but now there's going to be an integration where behavioral health is going to become part of the whole physical health of a patient, and they are now moving this as an integration. So what we want to do for you today, I'm going to set the table, is we're going to speak about if you're even registered to bill through New Jersey Medicaid, because if you're going to provide either phase 1 or phase 2 of the services that are outlined, you're going to have to be registered. But for those of you who are already registered, now you're going to have to contract with these 5 MSOs, as well as have your providers credentialed so that you are going to have the ability to bill for the services that you are providing. So we have a lineup of healthcare experts in this field who are going to walk through from best practices in billing. We're also going to review contracting, and then we're going to spend the majority of our time on credentialing, because if you are not properly credentialed, then your claims are going to come back when you submit them. So we want to just provide you with an overarching view of what is taking place on January 1st, And at the end, we will save time for questions. And if we run out of time, we're then going to make certain that we contact you individually with the questions that you have submitted, as well as provide you with our contact information so that you can then reach out to us if you think of any additional questions along the way. So what does phase one cover, right, as this integration into these managed care contracts? So you have your outpatient behavioral health services, outpatient counseling, partial hospitalization, right? Here's a list, as well as substance disorders, abuse disorders. So here's a list of what the first phase out beginning 1/1/25. There's also going to be a phase 2 and phase 3. Phase 2 is going to be hospitalization and opioid treatment programs. But what we're going to cover today is phase 1 because that is what's going to impact your practice or health system. Overall, there's 3 overarching goals that the program is trying to address. First, to increase access to services with a focus on member-centered care, right? In healthcare, we're moving to value-based care. So this is another initiative to look at the entire patient in their entirety instead of a segment. So that's one goal. Also to integrate behavioral health and physical health back to the whole person care with hopefully improving healthcare outcomes. And additionally, provide appropriate services for members in the right setting at the right time. All providers, I've repeated this a few times, you're going to hear it all throughout our presentation, right? You're going to now have to transition from fee to service to now billing under these or partnering with these managed care organizations. So as I have mentioned, the first step would be if you are not enrolled and you are going to be billing on either a phase 1 or phase 2, your first course of action would be enrollment. Now, there's another slide that we're going to present whereby there's links to the training courses. There are so many courses that New Jersey has available, and for enrollment, they actually take you through step by step as to the 2 forms that are available, how the fee for service form provides a little bit more in the way of flexibility compared to the managed contract form, but they walk you through it step by step. If you're already enrolled in New Jersey Medicaid, then your next step for you would be to join these MCO networks, which Grace Mack, our healthcare attorney today, is going to walk you through what is important in contracting with the MCOs. We're going to spend the bulk of our time, as I have mentioned earlier, on credentialing, right? And Rick is going to walk us through and even provide examples, some case studies in credentialing, and then also claim submission. So we're going to discuss with WICS today, right, what's the best way to submit clean claims and your best chance for reimbursement and not having denials, and some best practices. And as I had said, here are some links. The first, there's 4 or 5 training sessions, a little lengthy, but you could divide them up. On December 5th, they're actually providing an answer and question. They're calling it a drop-in session from 2 to 4, whereby you can reach out, pose your questions to them, and they will make themselves available to you. This is the only session they have available right now prior to going live on 1/1/25, as well as there's some Excel workbooks, and more information and content will be available as we continue with our webinar this morning. So now I'm going to hand this off to Wix Moffitt. I've worked with Wix for many years. I'm going to give him the opportunity to introduce himself and let you know all that he can provide to you and your organization in his area of specialty. Wix. I think we're having some difficulty right now and that we're unable to hear Wix. Give us a moment.
Okay, can you hear me now?
Yes, we can hear you now. Thank you.
So sorry about that. So I was just saying, with regards to my experience, I've been doing this for over 25 years. I've been doing it for a really long time. And originally, 25, 30 years ago, compliance was done, by some guy in a windowless basement in a cubicle in the bottom of a hospital, and really nobody paid attention to it. And it has come a long way since then. But I wanted to talk very quickly, and Carla, you don't need to go back, about the title slide. And it says mandatory compliance requirements. And we often, deservedly so, get the question, well, who's mandating this? And this stuff is all still so new. I haven't seen any mandatory like attest, like in New York, for New York Office of the Medicaid Inspector General, you have to attest once a year that you have a compliance program, that you're training your employees, you have a compliance officer, and you're auditing your charts and all that. It's almost the way we all do our taxes every April 15th. I have not seen that yet, but what is mandatory in anybody's conditions of participation, whether it be with Medicaid, Medicare, United, Aetna, whomever, they have something called conditions of participation, usually buried somewhere on like page 72, saying that it is mandatory to participate in this program. You must comply with all local, state, and federal regulations. So this is not just a good idea, it is actually mandated. So to continue on, to try and make it a little bit simple, compliance starting points. If you were just sitting down with me and asking me, hey, what is it I need to do, just very in a rudimentary way, to pull together my compliance program, I would say you need to write up your policies and procedures, pull together your written bureaucratic manuals, make sure everybody in the organization is trained, obviously document all of this stuff along the way. And very importantly, because this is where the money is, you want to have some type of regular coding and chart audit being done. Number one, to make sure that you're staying within the guardrails, but number two, to make sure that you're being reimbursed properly. Next slide, please, Carla. So with compliance, or with this being new, I mean, compliance is not new. They go off what they call the 7 elements of compliance. That's the main, and you can just Google this. It's OIG 7 elements of compliance. I'll show you a slide on it, and I think we're sending this to everybody as well. But those are the main things if you want to make sure that you're putting yourself in a safe harbor or a defensible position, is maybe an easier way of saying that. And the other thing that's different about this is everybody's aware of HIPAA. I get that, but they have something called 42 CFR Part 2. You don't need to remember that actual phrase, but what that is that now includes what they're now calling substance use disorder, SUD. It used to be substance abuse disorder. It used to be addiction services. I don't know what it'll be, next year, but it's essentially all the same thing. And really what that is, it's HIPAA on steroids, because anytime you get that type of information, protected health information on a patient's medical chart, it needs to, you need to take a lot of extra steps and precautions to make sure that you are meeting that regulation. It often includes implementing, extra safeguards such as data segregation, advanced consent management tools, and the list goes on. We're trying to keep this relatively quick, but do not neglect that, please. Next slide, please, Carla. So these are the 7 elements of compliance. Next slide, please, Carla. And we always use acronyms to try and remember everything. And we have something called ICE RACE, which is implement written policies and procedures. That's what I mentioned earlier. Write up your documentation. Appoint a compliance officer. Educate and train all employees. Make sure there's a reporting mechanism for people to report back to you or communicate with you that there's been a compliance issue. Auditing and monitoring, just that needs to be done on a regular basis. You want to communicate disciplinary guidelines. The reason I'll mention this for a second is in many organizations, you know, one of the doctors who might be the hot shot or the owner of the practice, they're like, yeah, she always makes these mistakes, but you know what? She owns it. That doesn't fly. You need to treat everybody with the same standards. And then enforcement, just make sure that you actually implement those corrective actions. And of course, document everything along the way. I would, and almost every sentence like that. There are ways to get help on this too. I mean, certainly the people on this call, but sometimes like your medical malpractice company might be able to help you. There are ways to do it. It's not all just bad news and extra work. And I'm getting to the good news part in a second. Next slide, please, Carla. So we call it compliance as a profit center because, as I've mentioned, I have been doing this for a long time, and people have always hated compliance. I've come to terms with that. And what we've discovered over the last few years with all this value-based care, with all the coding and chart audit, that there are a lot of areas in there where you may be missing revenue opportunities. So you can turn this around and have it, have it increase the bottom line and the revenues of your practice. Next slide, please. And where this one really just goes into it, this can increase your patient volume, which is more revenue. It really combines the physical and behavioral outcomes. So it's going to make your patients stickier. I mean, in any business, what you want is a recurring revenue, and having return patients that are relying on you for these extra services is great. Not to mention how great it is for the community, because behavioral health, certainly in the last 10 years, has become such an issue, and it's been hyper focus on that, I would say, since COVID. So it's really a great way to expand your patient base, get your practice out into your community, and with other things like telehealth, you can really jump on that. And really the main thing is that there's a lot of revenue out there, and the best way you can find that is by doing an audit. Some places have the ability to do an internal audit, which is fine, or an external audit, which is recommended, because then you don't have the fox guarding the hen house. And if you have somebody recommending it externally, you may be able to really have them find areas of missed revenue opportunity, and then they will stand behind it if you do get audited, because it does seem like audits will certainly increase on all of this, especially with the new administration and AI looking for, looking for mistakes and trying to essentially get money because the government is broke. Next slide, please. Okay, Grace, you're up.
Good morning, everyone. Hi, I'm Grace Mack. I'm an attorney with the law firm of Valence, Goldman and Spitzer here in New Jersey. I'm co-chair of our health law department. So like Debbie and Wix, I've been doing this for a while. helping to represent physicians and other providers. So this is an area that's very interesting to all of us, and it's a pleasure to be here this morning. And I want to thank Debbie and the Sachs firm for putting this together. So I'm going to dive right in. So the enrollment process consists of two basic components: the credentialing component and the contracting component. The two run in tandem. So Rick, who has the more interesting part, the credentialing side, will cover that, and I'm covering the contracting portion. So the MCOs have been saying that the process should take around 60 days, although it may actually be quicker. So as Debbie noted earlier, the first step is to enroll with New Jersey Medicaid if you're not already done so. That's not contracting with the MCOs, but that has to be done even before you move to the MCO portion. So if you're new to MCOs on the Medicaid MCO side, then you have to enroll and contract with any of the MCOs that you want to move forward with. If you are already enrolled with one of the MCOs, you may not need to enroll or credential, but you definitely need to review your contract. Your contract may be narrow, and it might not contain some of the services that you want to now participate in, and there might be some other updates. So if you're already enrolled, it doesn't mean that you may not have to contract. You definitely need to review your contract and reach out probably to the MCO that you're already enrolled with to see what else has to be done. In the whole process, the first step is to contact the MCOs that you want to enroll with and ask for an application. They each have a little bit of a different process, but most of it is just either an email or a request for an application. The training sessions had a contact information and the team for each one of the MCOs and how to reach them. If you need that, I'm sure Debbie or I or any of us can get you that information that's contained in those training seminars. There's specific contact information for each one of the MCOs. So you would reach out and you would ask for their contract. And in addition to the training that's on the site from Medicaid, each one of the MCOs also have various training materials in their side as well. So that's important, not just to get enrolled, but it also gives you some insight into their policies on reimbursement and coverage and different procedures like that. So it's important that you have to keep that in mind as to each particular MCO. So I'm going to first cover some potential traps or pitfalls that might be in the MCO contracts. You can go back to the slide before that, Alex, if you don't mind. Some of the traps or pitfalls that might be in some of these contracts, some of the terms that might have some more information within them that you might not be aware of. And some of these traps or pitfalls are legal, but some of them are just operational. So you want to make sure you're aware of what the requirements are under that plan. So you might have to implement some different operations in your way of doing things to make sure that you get reimbursed. So I'm going to cover some of these terms broadly and not do a deeper dive, because only if we have time at the end, because I know everyone's really wants to get to the enrollment process, but these are just some basic potential contract terms that could come back to bite you later if you're not aware of them. And I have a checklist here, so my slides have a few pages of various checklist sections you should look at. So this will be in the materials for afterwards. I don't expect to go through it all now, but when you have a contract, you might want to go through these and just see if they cover what you understand them to cover. So the important term, of course, is the payer. Who is the payer under the plan? So there's going to be the different MCOs, but you have to see what that covers even under that MCO. And each payer is not the same. So some of the terms are going to be required under the program or required under the managed care contracting law, but some of the terms are going to be in the discretion of the payer. So they're not all going to be the same. So don't just sign the contract. Go in with your eyes open so you're aware based on the payer. The next really important definition is covered service. What is covered under that agreement? You have to be careful. There are specific services that you want covered or not covered under that plan that they're listed. So that schedule to the contract is going to be very important. And there might also be limitations on who can provide the covered service, what type of provider, I'm lumping this under covered service, but some of the payers have different rules on whether you have to separately enroll supervised providers. So if you don't follow those rules, you might end up not getting reimbursed and end up with an audit and having to hire WICs to help you out with that. So you have to be careful on each contract's requirements as to who can provide it and whether they have to be credentialed or just listed on a roster, or whether they won't cover it at all. You can move to the next slide, Alex. Next slide, please. Great. So the obligation to pay, what are the time periods? You have to look at those so you're aware. I mean, there's not too much you can do about it, but there's under the program, they're supposed to follow certain standards. 90% of claims are supposed to be within 15 days, 30%, 90% in 30 days. So and most of them within 45 days. Another important provision is the retroactive denial of claims. So you don't want to have a claim that you've submitted and then it gets retroactively denied. Certainly you have to watch retroactive authorizations if you don't have the authorization at the time of service. Under this new program, it provides that they must accept a retroactive authorization for a minimum of 5 days. Any time beyond that is determined on a case by case by the applicable MCO. So that's another provision that could be case by case or payer by payer. The dispute resolution process is important, not for right now, but for if you should ever need to use it. Next slide. Sorry, Alex, there was a slide on payment. Fee schedule, that was, can you go back to that one? We somehow passed over. No, it's earlier. There it is. Okay. Yep. Perfect. Sorry. Now the fee schedule, obviously this is probably the most important provision in the contract. You want to see what your fee schedule is. And under the program, the MCO is required to pay providers at or above the fee for service payment. But what that means, above or at, is going to depend on the payer. So they have discretion. So you really have to look at the rates and negotiate that if possible with the MCO. The time period for submitting claims, you have to make sure you're careful on that so you don't end up with denials. Next slide, please. Maintaining records retention policy. This is another one of those that's maybe more of a practical than a legal. Whatever their requirement is, make sure that it's consistent with your internal operations. Audits, back to do we want WICs involved? You got to be aware of the whole audit provision in your agreement. Policies and procedures, this is also something operational. It's not just your contract that governs your behavior under this and your ability to get reimbursed. It's going to also depend on your following their provider manuals and other policies that they have. So you really need to review those as well. Next slide. Utilization management. We're not going to get into this, but this is also, operational and what you have to really be aware of the procedures that they are requiring. Reporting of data. Sometimes there's requirements of reporting specific data back to the payer. Next slide. The contract term also, and all these on this whole page, contract term without cause and for cause. You want to look at the contract term and the without cause provisions. You want to give yourself some flexibility if you don't like the contract after a certain amount of time. But then remember, on the other hand, they will have the same right if you have a short without cause provision. So it's something to focus on in your review. Next slide. Government healthcare program provisions. So unlike a managed care contract you would have with a commercial payer, this is a managed care contract with a government payer. So there's going to be some additional regulatory provisions in here. Even as Wix pointed out, the HIPAA and privacy requirements for substance use disorders is enhanced. So there's also times when the payer will put some things in there that aren't necessarily required by law under the government programs, but they want to put it in there. So you have to be careful that there's not additional requirements put in there. So you really need to understand some of these, both legally and, as I pointed out before, operationally, if you have to put some more protections in place in the way that you operate. Next slide. And then there's the usual miscellaneous provisions. Sometimes there's provisions in here that allow the payer to unilaterally amend the key terms in the contract. This is where you want to make sure that there's some kind of advance notice of that so that you can get out of it if you're not happy with these changes. Another factual thing, sometimes the provider agreement has a provision in there about types of insurance that you're supposed to maintain. So if they have things in there, you better check with your insurance to make sure you have the types of insurance that are required or to negotiate around it. Indemnification, that's another thing that is very important. If they have something in there about you're indemnifying them, but they're not indemnifying you. So you want to take a careful look at that provision to see that you're protected. I think that's it. And I think I can hand it off to Rick. Thank you. Thanks very much. Any questions, please feel free to. You can reach out at the end or email me.
Grace, thank you. Before we go over to Rick, I just wanted to remind providers that, so far we're making the assumption that we're speaking to mental health providers, but we also do have primary care providers who also offer mental and behavioral health services. So we just want to remind those providers that there are waivers that are available, and then to make sure that you have the appropriate coding, right, so that you are then reimbursed for these services. So just wanted to point that out, as well as in our discussions together that Grace has just gracefully presented to us, that there is also room for negotiation in these contracts. So with that, now we're going to hand it off to Rick, and Rick actually is going to take us through credentialing, right? So he has a lot of information to provide to us, and I will let Rick take it from here.
Yeah. Good morning, everybody, and thank you. Great to be on with everyone. So I know this topic can be dry, so I'm going to take it from a little bit of a different perspective to talk more about the application process, as if that's not dry enough. But the process here is quite important, and in our experience, we've seen that this is the area where companies and providers oftentimes get tripped up and have delays into getting into their plans and programs. So before I start, I want to, of course, thank the organizers for having Licentium be part of this esteemed panel. I am the co-founder of Licentium. I am a attorney and pharmacist, though our company is really focused on providing innovative cloud-based software. And it's backed by a team of subject matter experts that work every day to streamline the enrollment, credentialing, and provider data collection processes to make healthcare operations more efficient. So to that end, I'm joined by my colleague, Carla Acosta, who's Licentium's Vice President of Medical Affairs and Operations. And so we're going to talk a lot about the process involved, and some of it seems so straightforward, but we wanted to make sure that we cover the areas where there may be pitfalls or where folks get tripped up. So to start out with, we're talking a lot about New Jersey Family Care's carve-in, and what does carve-in mean? It simply means the integration of behavioral health services into broader healthcare plans or networks to ensure that these services are covered under the same umbrella as medical care, rather than being managed separately. So a lot of opportunity, areas of opportunity from a billing perspective. So very simple, I wanted to just unpack some of the terminology. So when you watch the training videos, or if you need to call the state, there you have a basic understanding of what the terms mean and in reference to. So very simple, fee for service, probably many of you know. Under this model, the providers bill the state Medicaid directly for services. And so currently, the behavioral health services for the general population are billed through this fee for service. And so the main takeaway here, as we've been talking about, is that specifically behavioral health services are now transitioning to a managed care model, or carving in. And so currently fee for service is still used for certain services, and members not enrolled in MCOs and those with presumptive eligibility. So about 5% of family care members are covered under the fee for service model. Now, managed care, what does this mean? So managed care, this model involves services managed by one of the 5 MCOs in New Jersey. So here, just to talk more specifically, we're talking about Aetna, Fidelis, Horizon, United, and WellPoint. And here, providers will bill these MCOs directly, and the MCOs receive state funding to coordinate member care and offer additional services beyond just the regular New Jersey family care benefits. The MCOs are also tasked with provider network management, care coordination, care management, utilization management, as Grace just spoke about, quality assurance, as Wix was talking about, and then administering the benefits on behalf of the state. Here, approximately 95% of New Jersey family care members are enrolled with an MCO. Next slide, please. Now, I wanted to mention as we go into this that the chat box is open. If anyone has any questions for any of us at any time, please feel free to ask it, and we are monitoring the chat boxes. So, you know, just again, to talk a little bit about terminology, because it matters as you're going to start thinking about what you need to do to prepare for this transition. Again, a provider can be any healthcare professional or organization providing medical services. This includes physicians, hospitals, and in the case we're talking about behavioral health, so we're talking about behavioral health organizations, and opposed to the terminology that the state likes to use as a rendering provider, which is a healthcare professional who's delivering the care to the patient. And in this case, it's an individual, a licensed individual. Key in billing, again, the process of entering the necessary information into the billing system to ensure accurate reimbursement. And then members are individuals who are covered by the insurance program. Pretty straightforward, but again, terminology matters as you're looking through, you know, volumes of documents and going through to try to figure out, you know, what exactly you need to file, which we'll get into. So if you could go to the next slide, please. So again, not to be redundant, I think this has been covered, but again, the whole point here is that behavioral health, again, what does it include? It includes mental health services and substance use disorder services. And really the purpose of this, New Jersey, and there are other states across the country that's working on carving in the reimbursement, so prioritizing the whole person care. And this is the change that's happening January 1st of 2025. Again, New Jersey's goal here is to increase service access, integrate behavioral and physical health for whole person care, and provide appropriate service for members. Next slide. So now let's talk about the timelines, because this is really what matters here the most. Right now, we're in December, and really these changes started to take effect in terms of soliciting the changes, that the state's making these changes in September of this year. So New Jersey is taking a phased approach to shifting behavioral health services from fee-for-service to managed care. And really here, what's important, what I've highlighted here is that the phase 1 implementation, again, focuses on outpatient behavioral health services, counseling, hospitalization, and patient care. So that's phase 1. Again, thinking about what type of service your organization or you as a provider, rendering provider provide. These are the areas that will be covered and what you'll be responsible for doing come January 1st, which we'll talk about in a minute. Phase 2 and phase 3, as you see here is listed. Phase 2 will encompass residential and opioid treatment programs, rehab, withdrawal treatment. Again, the timelines from the state have not been issued yet, and we'll be keeping a close eye out on that. And then, of course, phase 3 will be additional behavioral health services, overdose screenings, and support services. So first thing to consider, what type of service do you provide? Do you fit within phase 1? And if so, what do you do? Right? So the first is, here are what actions you as a member would have to take. So the first is you have to get enrolled with an MCO and review the new contracts, which Grace just spoke about. That's really the most important thing. And I'm going to talk about, again, what that process means. And in not all cases will you actually have to do anything. So speaking of that, we'll go to the next slide. Okay. So the first criteria here is that enrollment is the enrollment process. And what is the enrollment process? So this is the process by which providers are approved to deliver services to Medicaid beneficiaries. So again, if you're already enrolled, this is for providers and rendering providers, and that is for if you're not currently part of New Jersey Family Cares. In other words, you are brand new to New Jersey Medicaid, and you want to provide services covered under phase 1 or phase 2 of the transition. The first step is to get enrolled into the New Jersey Family Cares program. So step 1, determine your application type. Let's talk about that. So the full fee for service gives you flexibility. It allows you to bill for any services that are payable for fee for service. For individuals, for licensed practitioners who want to bill Medicaid directly on their own, so if you're a nurse practitioner, an MD, a DO, psychologist, the applications will vary by provider type. And then for group and facilities, for administrators who are enrolling the entity or a group practice to bill Medicaid, the application will depend on your group and the provider type there. And that's also including, like, for example, 21st Century application or MCO. These limit you to billing for managed care services covered under phase 1. And again, here is the criteria. If you're brand new in New Jersey Medicaid, you're not enrolled, then now's this time to start collecting your documentation to file for enrollment. And enrollment process normally takes about 15 days, and it'll be opening up January 1st in 2025. Okay, next slide, please. So what are the required documents? It seems pretty straightforward, but this does take time. So if you're an individual provider, meaning a rendering provider, you need to start to collect your NPI number, of course, your Social Security number or your TIN, your New Jersey state license, your DEA license. Now, the state license, just to talk about that for a minute is important. You have to make sure that it's been renewed and in good standing. You have to do a verification check on that license. You'll need a voided check as well. Your contact information, Medicare number, background check. These are all really important because if there are any mistakes or there's mismatching of information on the applications, it will create delays. It will slow things down. And of course, the first thing you want to do is get enrolled in order to start billing. And we've seen this time and time again where businesses end up having a slower process because there's something not right in their documentation. Now, if you're a group or facility, similarly, you'll need your NPI, TIN, of course, your business license, IRS letter, W-9 form, business contact, of course, a voided check. So again, you could take a look here, but these are the things that you're going to start to do right now. And really important to start to collect all these documentations. Can take a long time, especially if you're working with a large rendering provider base, to reach out to them and start to collect this information. And then, of course, if you're an owner of a company, you own the practice, you'll have to have your disclosure of ownership and control interest. Usually it's anyone who owns 5% of the company or more will need to be involved in this process. you'll need the authorization form and then the provider agreement. So again, there's a lot of documentation involved, and this is if you're not currently enrolled. Now, that may not be applicable if you're already enrolled. Then we will go on to talk about the next steps, which is the credentialing process. So let me pause here and see. I don't see any questions coming out in the chat box yet, and then turn over to Carla. Carla, do you have anything to add into here before I go on to credentialing?
No, everything looks perfect so far.
All
Yeah.
right. Okay, so if you don't mind going to the next slide. So step 2, once you're enrolled, sorry for the text, it looks like it came out a little funny here, but credentialing is the process by which the MCOs verify and assess the qualifications, experience, and professional background of the healthcare professional, the licensed healthcare professional who wishes to join the network. And then again, I won't get into contracting, we just spoke about it. So again, here, you have to select which MCO you want to credential with. Again, in terms of the different MCOs that are available, there's Horizon, Aetna, Fidelis, United, and WellPoint. That's what the state of New Jersey has partnered with to provide the MCO service. The only, again, thing to consider here is that specifically for Horizon does require you to contract before you credential, opposed to Aetna, Fidelis, United, and WellPoint, which allows for contracting and credentialing simultaneously. So again, when you're thinking about timelines, just something to take into considerations. Now, what are the changes for 2025? MCOs must process complete credentialing applications within 60 days. And then MCOs do integrate and have to integrate the information from a third-party platform, CAQH, into their credentialing process to reduce the provider burden and streamline the data entry. So once you've selected which MCO you want to credential with, then you'll move on to check if you need to credential with other MCOs or be listed on the roster. You'll have to complete your forms and documents and then submit the application process to complete the process. Okay. Next slide, please. Okay, so again, one slide back, please. Okay, so again, this is very similar to the enrollment. This is redundant information, again, that you'll be required to provide for credentialing. Again, enrollment is into the Medicaid program for the state. Credentialing is with the managed care organization, the MCOs. Okay, so just differentiate the terminology and the contracting. Again, the enrollment, the credentialing will be for the group, and then you can also credential individual rendering providers as well. And so just a quick note, if you haven't already, do consider if your providers have a CAQH, if the CAQH is updated. CAQH is generally where healthcare providers store and manage their credentialing enrollment data. It does help to streamline the process. Again, it's not the end-all be-all for the process, and just because you have CAQH doesn't mean that you're complete in your documentation. Really, the documentation collection process ends up being usually the most painful and time-consuming part of it. And so it's great that we're having this conversation now, so you could take the month of December to start to collect all the information needed, and then file and submit your applications in January. Okay. Next slide. I'm almost done here, and then we'll go into just a couple of case examples. And so, again, who should enroll with the 5 MCOs? Again, I've listed them here. Really, when we're right now in terms of phase 1, we're talking about these are the different types of licensed healthcare professionals: psychiatrists, advanced practice nurses, physicians assistants, psychologists, etc. Again, the ones that would be providing the type of service that could be potentially covered under this transition into MCO for phase 1 of this program. Okay. Next slide, please. So I know that was a lot of information, and we have about 10 minutes. Again, open to any questions that anyone has, but I thought we could maybe walk through a few case examples. And I'm actually going to turn it over to my colleague Carla to go through some of these hypothetical case examples. And of course, I invite the other panelists to provide their insights into this, especially as it relates to contracting, compliance, and billing. So, Carla?
Yeah, next slide, please. Okay, so we will have like different cases and scenarios depending on where on the process you are. Let's say we have a case number 1. Dr. RM is a psychiatrist planning to start her telehealth practice at Smile, New Jersey in New Jersey. She recently learned about a new reimbursement change in New Jersey and wants to align her practice. What are the steps that she should take? First, she has to enroll at Smile, New Jersey in Medicaid starting in January 1st. Once Smile, New Jersey is enrolled in Medicaid, she can enroll herself, Dr. Miller, with Smile, New Jersey Medicaid. Then she has to create a CAQH account if she doesn't have one, and choose at least one MCO to credential. However, to maximize coverage and ensure that all potential new patients are covered, Dr. RM may be advised to credential with all 5 New Jersey MCOs. Next slide, please. The second case is the Garden State Clinic. It's a charitable behavioral health clinic that provides care to underserved population in New Jersey. The clinic is covered by both Medicaid and Medicare. What should they do now? So they are already enrolled in Medicaid. The first step will be revise a new Medicaid contract starting in January 1st. Then choose at least one MCO to credential the Garden State Clinic and the providers on the clinic starting in January 1st. Create a CAQH account for their rendering providers if they don't have one yet. The new credentialing can be retroactively applied up to 60 days for reimbursement. And as they were mentioned before, this is a negotiation that you will have with your payer. And again, to maximize coverage, New Jersey is ensuring that or encouraging that you should enroll with the 5 MCOs. Next slide, please. The third case is Dr. HG. He's the medical director of a counseling clinic in New Jersey that currently accepts insurance from Medicaid, Medicare, and Horizon. He recently received a flyer from New Jersey Family Care outlining new changes to the reimbursement model for behavioral health services in the state. Dr. HG is now tasked with understanding these changes and ensuring his clinic is compliant. What he should do. So first, he should revise a new Medicaid contract in January 1st, revise the new Horizon contract in January 1st. So he's done here. However, New Jersey is encouraging him to enroll in the rest of the 4 MCOs. There is any question here for the cases? No, you can go to the next slide. It's good. So there is like a little summary chart here explaining the 3 different scenarios or cases that you can have. The first one will be if you are brand new in behavioral health, you should do your initial consultation either with a third-party company expert on credentialing or with Medicaid. You should define your application type, do a payer consultation with the MCOs, start your initial enrollments, do enrollment maintenance, credentialing contracting, CAQH creation, and maintenance. Now, if you are already enrolled in Medicaid, you should do everything but the initial enrollment in Medicaid. And if you're already enrolled in Medicaid and the MCOs, you should just do the maintenance and check your contracts. Next slide, please. Any questions?
You know what, I have a question.
Yeah.
So for someone, right, it's early December, and I saw like throughout your case studies to at least enroll with one MCO. Is there one where there's more covered lives where the audience should start with that MCO if they're not able to then contract with all 5 immediately? That's just like a thought that came to my mind.
That's a great question. And actually that will depend on your practice and the type of insurance that your clients are having or like the demand that you have at your practice. Probably there are going to be some practice that the demand will be Horizon or United. So that will be depend on the organization itself where they should be enrolling. But the advice from New Jersey is to do the 5 altogether.
Right, right. So maybe then they can look through their billing software to gain that information just as a starting point to
Correct.
then start this process.
Correct. And from now, it's December now, they should be collecting all the paperwork that was presented before, and then starting the application in January 1st.
Okay, great. And we're also, so to all of our participants and those who will listen to the recording, we're going to present the slide deck. And on the slide deck, we also then have links to the New Jersey Medicaid trainings, as well as some other information that they provide. So for the MCOs, there's actually an Excel workbook where they then provide contact information to start this process. So that will be available as well. Not sure if any of our other presenters have any questions before we close out our session. Well, once again, we want to thank you. Thank you for taking the time. I want to thank our esteemed panelists who joined us today and spent time out of their schedules to put together a wonderful presentation and provide us with information as to this forthcoming change. You have our contact information, so please feel free to reach out to any of us, and we will make certain to respond to your questions and assist you and help you the best way possible. And I just want to wish everyone a wonderful holiday season. Thank you.